Okay, we're going to pick up now with the last little section of Chapter 5, which is Articulations and Joints. Articulations are the fancy name for joint. They're the points of attachment between bones, between cartilage, between teeth, etc. They're classified both by structure and by function. So when we classify them by function, we're going to classify them by range of movement, by the placement of ligaments, by the flexibility of tendons, by the shape of the bones. When we classify them by structure, that's going to be based on strength as well as flexibility. So our functional classifications include synarthrosis, amphiarthrosis, and diarthrosis. A synarthrosis, that prefix syn, means without. So this is a joint that is without movement. This is a joint that does not allow any movement. So an example of this would be the sutures within our skull. An amphiarthrosis is one that gives a little bit of movement. So the joints between our vertebrae are slightly movable, or our pubic symphysis is slightly movable. Diarthroses, these are the most movable joints. This is probably what you thought about when I told you we were talking about joints, right? This is our elbow, our shoulder, our knee, our hip. All of the very movable joints of our body are diarthroses. When we look at the structural classifications of our synarthroses, we have fibrous joints. The majority of our immovable joints are made of special fibrous connections, like our sutures, as I mentioned. The sutures joining the skull bones have that thin layer of articular tissue connecting them. There's also a syndesmosis, like the connection between our tibia and fibula, the distal articulation. Doesn't move, very, very fibrous in its connection. A gomphosis is the technical term for our tooth socket. Teeth are actually considered a joint because teeth are made of a bony tissue, and of course they insert on the maxilla, which is a bone, so they themselves have a classification as a joint. Interosseous membranes are also fitting within this. This would be like the radius and ulna articulation, where there's a large sheet of connective tissue surrounding the two bones. So those would all be fibrous joints. There's also cartilaginous joints. Cartilaginous joints can be movable in the case of a symphysis, as I mentioned the pubic symphysis as being a slightly movable or amphiarthrotic joint. This is where bones are joined by a piece of fibrocartilage. This would also be like the types of joints in between our vertebral bodies. That it's slightly movable in that aspect. A synchondrosis would be where hyaline cartilage is in those epiphyseal plates of our long bones. So this is a non-movable structure. That growth plate or epiphyseal plate is not a movable joint. You can't separate the epiphysis from the diaphysis. It forms what's called a synchondrosis. Then we get our synovial joints. These are very freely movable. This, of course, is the most common type of articulation. Let's talk about these in more detail. Here you can see some of the classifications I was mentioning. Synovial joints have a fluid-filled cavity called a synovial cavity. Excuse me. There are 6 different types of synovial joints, and we'll get into all of those eventually. The cartilaginous joints held together by that cartilage, permitting very little bit of movement, and then those fibrous joints which produce almost no movement at all. Here you can see the example of the synchondroses, the growth plate or the epiphyseal plates forming the boundary between epiphyses and diaphyses. This would be an example here of a synovial joint at our knee. The symphysis, such as the pubic symphysis. There's also, as I mentioned, excuse me, I'm having a cough attack here. There's also the symphysis in between the vertebral bodies. So let's get to know these movable joints a little more specifically. Synovial joints are a little bit more complicated because they have lots of moving parts to them, so there's lots of built-in protective measurements. There's lots of synovial fluid within these synovial joints. The ends of the bones are covered with a special type of hyaline cartilage called articular cartilage. We mentioned this before earlier in the chapter. There's a capsule that surrounds this cavity called a synovial membrane, and then there's usually ligaments that hold the joint together. There may also be fluid-filled sacs called bursa. Those bursa provide extra lubrication to reduce friction in the area. So let's talk about some classifications of joints. They can of synovial joints, I should say. They can provide a gliding motion where the flat bones kind of move back and forth or side to side on top of one another. This would be like our carpal bones, our wrist bones, moving or gliding against one another. Angular movements can increase or decrease the angle of articulating bones. This would be like flexing or extending, circumduction, abduction, and adduction, all moving body parts to change the angle that they make with our body. And here's some examples of these. Flexion and extension and hyperextension. Your body, just so you realize this, at an anatomical position is fully extended. If you go beyond anatomical position, that's hyperextending. If you're decreasing the angle, you would be flexing. So here you can see hyperextension and flexion as well. Flexion, extension. Flexion, extension. In this case, you're flexing the hip. In this case, you're flexing at the shoulder. In this case, you're flexing at the elbow. Here you're flexing and extending at the knee. Flexing and extending at the wrist. Circumduction is moving that arm in a circle, keeping the arm straight. And you can do that with your foot as well, kind of going medial and lateral, rotating or circumducting your leg. You also have the angular movements of abduction and adduction. Adduction being where you pull your body limbs toward, whoops, sorry, I have a jumpy mouse. Come on, computer. There we go. Adduction, where you're adding that arm to the body, or abduction, like you're being abducted and taken away from the body. You can do that with your hand as well as with your leg, abduction and adduction. You can also rotate. You can rotate medially toward the midline of the body or laterally away from the midline of the body. And here you can see rotating at the elbow, rotating at the articulation with the occipital bone. There's also special movements which are specific to certain areas of the body. Elevation, depression, protraction, retraction, inversion, eversion, dorsal and plantar flexion, as well as supination and pronation. So here you see some of these movements. Pronation, when you're turning your palm face down or backward. Supination is when your palm is facing up or facing forward. Opposition would be like when you're grasping something with your thumb. You may have heard of the term opposable thumbs. It's because your thumb can do the motion called opposition when you put your thumb and pointer finger together. Inversion is when you're rotating your foot medially. So in other words, moving your ankle so that the sole of your foot is pointing medial. Eversion is a little bit harder to do. Eversion is when you're trying to laterally rotate at the ankle. In other words, get that foot to point outward. Get that sole of your foot to point out towards the lateral side of your body. Dorsiflexion is when you are pointing your toes up and back, kind of up at your head, whereas plantar flexion is pointing your toes. That's typically what we think of when you say point your toes. You're going to try to make your toes as straight as possible, and that's what plantar flexion is. Elevation and depression can be related to your mandible, elevating your mandible as you close your mouth, depressing your mandible as you open your mouth. You can also protract and retract your mandible, pushing your jaw forward or pushing your jaw backward, protraction and retraction. So let's talk about some different classifications of these joints and how they move. So our synovial joints are classified by their types of movement. We know that they're all freely movable joints, but you can subclassify them by the specific movements that they do. So A planar movement would be a back and forth or side to side type movement. A hinge movement would be like an opening or closing type of a motion. A pivot would be a rotation. A condyloid would be where you rotate around two axes. Think about moving your thumb. When you move your thumb around, you're kind of rotating it up and down and back and forth at the same time. A saddle joint would be where you're rotating around three axes. Same with a ball and socket. They just have different structural formations. So we'll look at these. A plane joint would be like those joints between the tarsals here, in this case, literally just moving back and forth, gliding against one another. A hinge joint, providing that flexion and extension motion. A pivot joint would possibly be like this joint here, where you have the head of the radius and the radial notch of that ulna, allowing for a little bit of rotation. The head of the radius is just going to wiggle a little bit within this annular ligament as you pronate and supinate your forearm. There's condyloid joints between the end of the radius and the scaphoid and lunate bones, which provides this kind of rotating and biaxial bending and rotating motion that we can do with our wrists. A saddle joint would be like the joint between our trapezium and our thumb. The way the two bones sit together is kind of like a cowboy sitting in a saddle, which is why it's called a saddle joint, and that allows for that weird kind of rotating and hinge-like movement that we can do with our thumb. A ball and socket joint would be like the head of one bone fitting into the socket of another bone. Two big examples of this is at our hip joint as well as at our shoulder joint. So let's talk more specifically about the knee. The knee is the most complex synovial joint in the body. In fact, it's the most common injury of a joint is tearing that ACL, the anterior cruciate ligament. 70% of all knee injuries are related to the ACL, and that's because there's usually a twisting or hyperextension of the knee, which causes that ACL to rip. Let's take a look at some examples here. You have bursa in there, which are going to reduce friction. You have the patella or kneecap here. There's another bursa, reducing friction. Look at what it's actually doing. See this patellar ligament holding that patella in place? Well, that bursa kind of acts like a little piece of bubble wrap beneath that patellar ligament, so the patellar ligament doesn't rub against this hard bony surface and get torn. Here you can see the tibial collateral ligaments and the fibular collateral ligaments. These are just special ligaments attaching the fibula and tibia to the femur. There's also the quadriceps tendon coming down from the quadriceps muscle on the femur. And then if we cut all of this away, we can see more details here. You can see that ACL ligament. You can see the PCL ligament. There's also meniscus that are associated with our knee. There's a medial and a lateral meniscus. The meniscus is kind of like a cartilage pad. It's an extra piece of cartilage, in fact, to help our cushion our knee joint. Now, the majority of the wear and tear on our meniscus occurs on the lateral meniscus, because if you think about where the weight is being distributed when you stand up, because of the curvature of the femur, that lateral meniscus is actually getting more wear and tear than the medial does. Let's talk about the effect of aging on bone structure. Of course, birth through adolescence, more bone is being made than being reabsorbed. That's all that osteoblast activity. In young adulthood, there's kind of an equilibrium between bone making and bone breaking that's being lost. And as middle age begins to set in, more bone is lost than is made. And that has to do with hormones as well as nutritional depletions. The bones become more brittle. Rate of protein synthesis and collagen production is going to decrease. It's going to cause an overall loss in bone mass, which is going to result from the increased osteoclast activity because your body's constantly trying to maintain calcium homeostasis. Osteoporosis is the condition that will develop when the bone matrix demineralizes to a point that the bone becomes porous. The bones become weak, very susceptible to fractures. Spine, hip, femur fractures, all of our weight-bearing bones are more susceptible than, say, our humerus or radius and ulna. We don't walk around on our hands much. So usually it's those weight-bearing bones that are prone to injury with osteoporosis. Diagnosis usually depends on family history. People that have small skeletal stature, people that have smaller bones as opposed to people that are big boned, tend to be more susceptible. People that have low bone mineral density are also susceptible. You're treated with high calcium diets, vitamin D, exercise, because remember, exercise is going to put stress on your bones, which is going to make them grow. Also, medications that are going to block osteoclast activity can be used, like Bonivo. Here you can see what a normal bone looks like. This, of course, is spongy bone. You can see the trabeculae here, and then the trabeculae of an osteoporotic bone, which is much more porous. Arthritis is pain and swelling and possibly loss of mobility because of the wear and tear of joints. It could be specifically due to the lack of synovial fluid. It could be because the cartilage is just becoming thinner and more worn. Maybe the ligaments are becoming so inflexible and short that it's making joint movement almost impossible. Arthritis can be classified in different ways depending on the cause, as well as where it occurs. Osteoarthritis is the most common type. This is the arthritis of aging, so this is the wear and tear type of arthritis. The joint cartilage is basically going to deteriorate over time because it's being used so much. Constant friction between bone surfaces is going to lead to an inflammation of those joints, which can lead to muscle weakness because it's going to decrease the points of attachment, which is going to kind of bring on the cycle of wear and tear as certain things are starting to not work properly, other things stop working properly, etc., etc. Treatment includes artificial joint replacements, getting hip or knee replaced, as well as hyaluronic acid injections, that will help increase the lubrication between the joints. This is a diagram that comes from your book about a knee replacement. You can see what they do is they begin by shaving the surfaces of the bones there, in other words, removing all of the articular cartilage, and then they're going to use in some cases it's metal, like a titanium type of metal. In some cases it's artificial cartilage that they will adhere to the bone, and that way you don't have to worry about bone on bone contact. It's more metal on metal contact that's being done at that point. Rheumatoid arthritis is actually a different type of arthritis. This is an autoimmune disease, so it could actually begin in adolescent years or even during childhood. This is not something that's caused by wear and tear or age. This is where your immune system is literally attacking the joints, causing inflammation and deterioration of the joints. It can also be brought on by various bacteria. Some people argue that various vaccines bring on rheumatoid arthritis as well. That concludes Chapter 5.